Okay, let's unpack this. Imagine for a moment a silent war constantly raging around us.
Hmm.
Billions of microscopic invaders, viruses, bacteria, toxins, always looking for an opening. And yet, most of the time, we navigate our lives largely unaware, largely safe.
Right. It's quite remarkable when you stop and think about it.
How do we build this invisible shield, this fortress, around our health and around our communities? Today, we're taking a deep dive into a topic that touches every single one of us, yet often remains shrouded in a bit of mystery.
The whole world of immunity.
Exactly. The fascinating, intricate world of vaccines, immune globulins, and other complex biologic products. We're going to pull back the curtain on the incredible ways our bodies, aided by clever medical science, fight disease.
And what's truly fascinating here, I think, is that we're stepping onto a profound bridge. This isn't just one scientific discipline, it's really a convergence.
A convergence. How so?
Well, you've got microbiology, which studies those tiny invaders, right, than infectious diseases, focusing on how they spread and affect us. Immunology, of course, the science of our body's own defense systems.
Okay.
And even immunopharmacology, which looks at how drugs interact with those immune systems. Our source material today is a remarkably rich appendix from KATZUNG's Basic and Clinical Pharmacology.
A foundational text, really.
Absolutely. It gives us an incredibly detailed, expert-level look at these essential agents. It's like a masterclass in how these diverse scientific fields unite to create interventions that are quite literally life-saving.
And our mission today is to equip you with more than just facts. It's to provide you with a comprehensive understanding, the kind of knowledge that helps you connect the seemingly disparate dots.
Right, so you feel truly well-informed.
Exactly. Well-informed about something so fundamental to public health. We're going to explore not just that immunity works, but how it works, the different ingenious ways we can achieve it, and the profound, sometimes surprising impacts these advancements have had on society.
And the challenges, too.
And we'll even delve into some of the complex challenges and debates that still exist around them. It's about moving beyond simply knowing vaccines exist to understanding the intricate science, the public health rationale, and the societal implications that lie beneath the surface.
Which really brings up an important question right at the outset. How do we harness the body's own incredible defenses, or even, when necessary, borrow them to protect against illness?
Borrow them. That's interesting.
We'll explore that, connecting the what these products are to the why it matters for both individual health and global well-being. We'll truly get into the specifics that define active versus passive immunity, their unique applications, and their inherent limitations, giving you that depth of insight, hopefully, that comes from really mastering this information.
That sets the stage perfectly. Let's begin by examining the two primary strategies for building our defenses, what our source calls the dual shields active versus passive immunization.
Right. Two sides of the same coin, in a way.
These two approaches represent fundamentally distinct, yet equally crucial, strategies for protecting us from disease, each with its own strengths and ideal applications.
Exactly. And when we talk about vaccines and related biologic products, we're dealing with a dynamic field. These aren't just simple chemical compounds. They are living or derived biological entities.
Biological, that's key.
It is. They bridge, as we discussed, microbiology, infectious diseases, immunology, and immunopharmacology. This interdisciplinary nature is really fundamental to understanding their complexity.
And it's a field that's perpetually in motion, isn't it? I mean, our source, even at the time of its writing, subtly hints at this constant evolution.
Yeah, it mentions the rapid development of SARS-CoV-2 vaccines.
Right, with several already in phase 2 or 3 trials back then. That's a powerful reminder that this isn't stagnant science, but a dynamic, ever-adapting frontier, always pushing to find new ways to protect us from emerging threats.
Absolutely.
The fact that these products are complex biological entities
Yeah.
interacting with our incredibly intricate biological systems, well, it means their development requires an exceptionally sophisticated and nuanced understanding of the human body's defenses.
It truly is. This constant evolution underscores that our understanding and the tools we have are always being refined, always adapting to new pathogens and new scientific insights. It's a testament to the power of interdisciplinary research, and it means the landscape of immunity is always being reshaped.
Okay, let's turn our attention then to what most people immediately think of when they hear immunization. Active immunization.
The classic vaccine approach.
This is the strategy where your body does the heavy lifting, building its own long-lasting defense system.
Yes. At its core, active immunization is the administration of an antigen to a host.
An antigen being.
A specific part of the pathogen, like a protein or a sugar molecule, that the immune system recognizes as foreign. So you administer this antigen to induce the formation of antibodies and, importantly, cell-mediated immunity. The purpose is quite straightforward: to induce protection against infectious agents.
Like sending your immune system to a specialized training camp.
That's a great way to put it, a highly effective training camp where it learns to identify and neutralize a specific threat before the real danger hits.
And our source breaks down two main types of active immunogens used in vaccines: inactivated or killed materials and live attenuated agents.
Right, two main flavors.
What's the crucial difference between these two, and what does live attenuated truly mean? Because live sounds a bit scary in a vaccine context.
It does, but the difference is quite significant in terms of how the immune system is taught. Inactivated vaccines use material where the pathogen, be it a virus or bacterium, has been completely killed, usually by heat or chemicals.
So it's dead, can't replicate, can't cause disease.
Exactly. The immune system sees these dead fragments, recognizes their unique molecular signatures, the antigens, and learns to respond to them, all without any risk of actual infection from the vaccine itself.
Okay, that sounds straightforward. What about live attenuated then?
Live attenuated agents are fascinating. Attenuated means weakened. These are live viruses or bacteria that have been modified, often through really careful laboratory processes, like growing them in unusual conditions over many generations.
Weakened how?
So they can still infect cells and replicate, but they do so very inefficiently, very poorly, and rarely cause actual illness in a healthy person. They're sort of hobbled versions of the real thing.
So with live attenuated agents, your body experiences a very mild, controlled infection, almost like a dress rehearsal.
Precisely. Like a dress rehearsal or maybe a realistic sparring match rather than a full-blown dangerous fight. It's just enough to trigger a strong, comprehensive immune response, but not enough to make you truly sick, assuming your immune system is working properly.
Okay, so given these differences, why are both types necessary in our vaccine arsenal? Is it primarily a balance, like you said, between safety and potency?
That's a very perceptive way to put it. Yes, that balance between safety and potency is indeed a primary consideration. Live attenuated vaccines often induce a broader, more robust, and typically longer-lasting immune response.
Why is that?
Precisely because they mimic a natural infection more closely. Your immune system gets the full experience, if you will, sees the pathogen replicating, deals with infected cells leading to stronger memory, both antibody and cell-mediated.
But the downside?
Well, because they are still live, albeit weakened, they carry a slight theoretical risk, particularly for individuals with compromised immune systems. Their weakened defenses might not be able to control even the attenuated pathogen.
Right, so not for everyone. What about inactivated then?
Inactivated vaccines are generally considered safer because there's absolutely no replication, eliminating any risk of the vaccine causing the disease. But this often means they might require more doses or boosters to achieve sufficient and sustained immunity.
Because the initial immune stimulation isn't as intense.
Exactly. The training isn't quite as comprehensive, so both are absolutely critical tools because they offer different risk-benefit profiles and are suitable for different pathogens and different populations.
But the underlying mechanism for both is the same: presenting the antigen.
Correct. It's all about presenting that antigen, that specific molecular signature, to the immune system. This teaches specialized immune cells, like B cells to produce antibodies, and T cells to recognize and destroy infected cells to remember that antigen.
So when the real dangerous pathogen appears later,
The immune system is already primed. It recognizes the enemy immediately and can neutralize the threat quickly and efficiently, preventing or significantly lessening the severity of the illness.
that comprehensive training makes perfect sense, which is why the concept of an ideal immunogen is so important. Our source lists several desirable features, and I want to highlight a few that truly underscore the ambition here. First, complete prevention of disease, which seems obvious, but then prevention of the carrier state. Why is that particular feature so incredibly crucial from a public health perspective?
Ah, yes. This is a profoundly critical public health consideration, far beyond just protecting the individual. Preventing the carrier state means the vaccine not only protects you from getting sick,
Right.
but it also prevents you from harboring the pathogen and, crucially, transmitting it to others. Even if you yourself show no symptoms, you don't become a silent spreader.
Like Typhoid Mary.
Exactly like Typhoid Mary. She's an asymptomatic carrier of typhoid fever, unknowingly spreading the disease to dozens of people throughout her life. A vaccine that prevents the carrier state is an incredibly powerful tool for interrupting transmission chains.
So it helps stop the spread entirely.
Precisely. It allows for the possibility of disease eradication, and it's fundamental to achieving what we call herd immunity or community immunity. It truly protects entire communities, especially the vulnerable who can't be vaccinated, not just the individuals who receive the shot. It's a game changer for population health.
That's a truly powerful distinction. And then the source mentions production of prolonged immunity with a minimum of immunizations.
Also key, you want long-lasting protection without needing constant shots.
Right. And absence of toxicity, naturally, and suitability for mass immunization, meaning it should be inexpensive and easy to administer.
But think logistics. For a global campaign, it needs to be practical.
It sounds like a remarkably tall order, balancing all those ideals. It's like training a city's elite defense team. You want them to recognize the bad guy, the antigen quickly, neutralize him effectively, and remember him for a very long time.
Ideally after just 1 or 2 intensive training sessions, exactly. And it needs to be safe for the whole team and affordable for the city.
That analogy perfectly captures the multifaceted goal, achieving maximum efficiency, safety, and long-term effectiveness on a population scale, making it practical for widespread public health campaigns.
That's the holy grail of vaccine development.
Given all that, it makes sense that active immunization is generally the preferred strategy. Why is that? What makes it the go-to approach whenever possible?
Its preference stems largely from the durability and comprehensiveness of the protection. Active immunization leads to higher antibody levels that are sustained for much longer periods.
So, less frequent shots over a lifetime.
Right. And, crucially, it often develops concurrent cell-mediated immunity, which involves specialized T cells directly attacking infected cells. This offers a more comprehensive, multi-layered defense beyond just antibodies.
And the critical concept here is
Immune memory. Your body doesn't just clear the immediate threat presented by the vaccine, it remembers the antigen, often for years or even a lifetime. It can mount a rapid, potent response upon subsequent re-exposure to the actual pathogen. This sustained, durable protection is unique to active immunization.
But it has a significant defining limitation, doesn't it? It's not instant.
Precisely. That's the Achilles heel, if you like. Active immunization requires time for the immune system to go through that training process, to learn, mature, and build that robust long-term defense.
So it takes days, maybe weeks.
Exactly. It's generally inactive at the very moment of a specific exposure. So if you get bitten by a rabid animal now and you haven't been actively immunized against rabies before, starting the vaccine series now won't protect you from this exposure immediately.
Because the disease progresses too fast.
Correct. Our source gives a perfect, practical example that illustrates this limitation and how we overcome it. For parenteral exposure to hepatitis B, meaning exposure through a needle stick or maybe sexual contact.
Okay.
In that situation, concurrent hepatitis B immune globulin, which are preformed passive antibodies, and active immunization with the Hep B vaccine are given simultaneously.
So both at the same time. Why?
The preformed passive antibodies provide immediate temporary protection. They're like a temporary shield, a crucial buffer. Meanwhile, the active immunization starts the slower but ultimately enduring process of building the person's own long-term immunity. It's a brilliant combined strategy using both shields.
That example perfectly bridges us to the other side of the coin. Passive immunization.
The borrowed defense.
If active immunization is about your body building its own defense, passive immunization is about borrowing a ready-made defense.
Indeed. Passive immunization consists of transferring immunity to a host using preformed immunologic products, ready-made weapons, essentially.
And from a practical standpoint, this almost exclusively means
Immunoglobulins, which is just the scientific term for antibodies. Our source makes a crucial point here. While the immune system does have cellular components like T cells that provide immunity,
right.
Passive administration of these cellular components is generally avoided.
Why is that? Sounds powerful.
It sounds powerful, but it's technically incredibly difficult and, more importantly, associated with severe, potentially fatal risks like graft versus host reactions.
Graft versus host. Can you break that down quickly? What is that?
Certainly. Think of it this way. When you introduce foreign immune cells from a donor into a recipient, say, T cells, those borrowed immune cells, can, in essence, mistake the recipient's own body tissues as foreign invaders.
Oh, wow.
Yes. They then mount an immune attack against the recipient's healthy organs and tissues. It's a profound and dangerous form of rejection where the graft attacks the host.
So the cure is worse than the disease, potentially.
In many cases, yes, which is why, for practical passive immunization, we rely on the simpler, safer transfer of preformed antibodies, these immunoglobulins, rather than whole immune cells.
Okay, so we're talking about ready-made defense, a shortcut, like bringing in a perfectly trained SWAT team that's already on standby.
Exactly that.
And these immunoglobulins can come from either animal or human sources, the source mentions. What's the implication of that distinction?
That's correct. The source matters quite a bit for safety and efficacy, as we'll see. But regardless of source, these immunoglobulins might contain high titers, high concentrations of antibodies specific to a certain antigen. Think antibodies specifically designed to neutralize snake venom or tetanus toxin.
Highly targeted.
Yes. Or they might be what's called pooled immune globulin. This is derived from the plasma of thousands of healthy human donors, meaning it contains a broad range of antibodies reflecting the common exposures and vaccinations found in the general population. This offers more general, though less targeted, protection against common infections.
So, general backup versus a specific weapon.
A good way to think about it. The key, regardless of the source or specificity, is that these antibodies are already formed, perfectly shaped, and ready to act immediately upon administration.
So when is passive immunization absolutely essential? When do we need this borrowed immediate defense? Our source outlines 4 critical scenarios.
Right. The first scenario is for individuals who are unable to form antibodies themselves. For instance, people with certain genetic conditions like congenital agammaglobulinemia,
Where their body just can't make enough antibodies.
Correct. For these individuals, passive immunization, often given regularly as immune globulin infusions, is a literal lifeline. It provides the defense their own bodies cannot generate.
Okay, that makes sense. What's the second scenario?
Second, it's crucial for the prevention of disease when there simply isn't enough time for active immunization to take effect. This is typically after a known or suspected exposure to a dangerous pathogen.
Like the rabies example you mentioned earlier.
Exactly. If someone is potentially exposed to rabies, they need immediate protection because once symptoms appear, the disease is almost invariably fatal. Rabies immune globulin provides those immediate neutralizing antibodies, buying critical time for the rabies vaccine series, given concurrently, to work.
So post-exposure prophylaxis.
Precisely. And the third scenario. For the treatment of certain diseases normally prevented by immunization, but where the person is already sick.
Like tetanus.
Tetanus is the classic example. If someone presents with active tetanus infection, the muscle spasms, lockjaw, immediate neutralization of the circulating tetanus toxin with tetanus immune globulin, or TIG, is absolutely vital for survival, alongside other supportive care.
Even if they get the vaccine later.
Yes, they likely would get the vaccine too for long-term protection, but the immune globulin provides the immediate antitoxin action needed right then and there. And finally, the fourth scenario.
Yes.
Passive immunization is essential for the treatment of conditions for which active immunization is simply unavailable or impractical. There's no vaccine for it.
That makes perfect sense. Can you give us some compelling examples from the source to illustrate these points, particularly for that last category where active immunization isn't an option? The source has a great table on this.
Absolutely. Table A3 in KATZUNG's is full of them. We mentioned rabies immune globulin for post-exposure time is absolutely critical there.
Right. Another powerful example is snakebite antivenin. Our source specifies it could be equine or ovine, meaning derived from horses or sheep.
Animal sources.
Yes. And crucially, there is no active vaccine to prevent snake bites. So if you're bitten by a venomous snake, you need immediate preformed antibodies to neutralize the venom and prevent severe systemic effects, organ damage, or even death.
A true emergency intervention.
Definitely. Similarly, botulism antitoxin, often also from equine sources, is given for the treatment of symptomatic botulism. This is a severe paralytic illness caused by a bacterial toxin. Again, no active vaccine readily available for the general public, so immediate neutralization with antibodies is key.
And you mentioned bone marrow transplants.
Yes. For individuals undergoing bone marrow transplantation, pooled human immune globulin, IVI, is often given prophylactically preventatively.
To decrease the risk of various infections during the period when their own immune system is severely suppressed. It can also help modulate the immune system and potentially reduce the severity of graft versus host disease, which we discussed earlier. These examples truly underscore the rescue or emergency nature of passive immunization, providing critical, rapid protection when other options are unavailable or simply too slow.
This brings us to a really fascinating and crucial point: the pros and cons. specifically the safety, efficacy, and half-life of human versus animal-derived antibodies.
Yes, the source distinction matters a lot here.
This is where the underlying biology gets really interesting and impactful, especially for patient outcomes.
It does. Let's start with human immunoglobulins. Our source states that complications from human immunoglobulins are remarkably rare, which is good news.
What kind of minor issues might occur?
You might experience moderately painful injections, especially if given intramuscularly or very rarely a sterile abscess, a non-infected collection of pus at the injection site. With intravenous immune globulin or IVG.
Given directly into the vein.
Right. Transient hypotension, a temporary drop in blood pressure and pruritus, which is just itching, can occur occasionally, but they are generally mild and temporary, often related to the rate of infusion.
But there's a specific caution mentioned.
Yes, a very important one. Individuals with certain underlying immunoglobulin deficiency states, particularly selective IgA deficiency, might occasionally develop hypersensitivity reactions to human immune globulin products, because even trace amounts of IgA in the product can trigger a response in someone completely lacking IgA.
So screening might be needed for some people.
Potentially, yes. And another critical note, which maybe not everyone is aware of, conventional immune globulin preparations contain small amounts of aggregated IgG molecules clumped together.
Aggregates.
Yes. If these aggregates are given intravenously, they will cause severe systemic reactions, like activating the complement system inappropriately. This is why conventional preparations must be given intramuscularly, unless it's a specially processed IVIG product specifically designed and tested for safe intravenous administration.
So generally safer, but with very specific and important considerations for administration route and patient specifics.
Precisely.
What about complications from animal sera? This sounds like it could be a bit more complex, given that these are truly foreign proteins being injected.
It is indeed more complex, and historically was much more dangerous before purification techniques improved. When antibodies are derived from animal sera from horses or sheep, for example, hypersensitivity reactions are a much greater concern.
How severe can they be?
They can range from mild local reactions like redness and swelling at the injection site, all the way to severe, life-threatening anaphylaxis.
Anaphylaxis. The severe allergic reaction.
Exactly. Or a delayed reaction known as serum sickness can occur, typically 7-10 days later, involving fever, rash, joint pain, and kidney issues. This happens because the animal proteins are fundamentally foreign to the human body, and our immune system can mount a robust inflammatory response against them.
So the body attacks the treatment.
In effect, yes. Our source notes that highly purified immunoglobulins, especially those from rodents like mice or lagomorphs like rabbits, are generally less likely to cause severe reactions compared to older, cruder horse serum preparations because they contain fewer impurities and the protein structures might be slightly less immunogenic. But the risk is still there.
So what precautions are taken?
To mitigate the risk of immediate severe anaphylactic reactions, rigorous hypersensitivity testing must always be performed before administering animal sera, usually involving injecting a tiny diluted amount intradermally first to check for a reaction.
A skin test.
Yes, and in rare, life-threatening situations where there's absolutely no alternative, like a specific snake bite where only equine antivenin exists and the antibody is deemed essential, a careful desensitization process can be carried out under close medical supervision.
Desensitization. How does that work?
It involves giving very small, gradually increasing doses of the animal serum over several hours, allowing the immune system to slowly get used to the foreign protein and hopefully minimize the chance of a massive allergic reaction when the full therapeutic dose is given. It's risky, but sometimes necessary.
So the body essentially sees these animal antibodies as foreign invaders themselves, even if they're there to help fight another invader like venom.
That makes perfect biological sense. It's foreign protein.
And how does this biological difference affect the half-life? How long these borrowed antibodies stick around in the body? Why are human antibodies so strongly preferred when possible?
This is a major defining advantage for human antibodies. They have a much longer half-life in humans. The source quotes about 23 days for IgG antibodies.
Over 3 weeks.
Right. Compare that to antibodies from animal sources, where the half-life is often much shorter, maybe a mere 5-7 days or even less.
Why such a big difference?
It's because the human immune system and protein clearance mechanisms are naturally equipped to recognize and rapidly degrade foreign proteins from animals. Our body sees them as non-self and clears them out quickly, whereas it processes its own human-derived proteins much more slowly.
So you need less human antibody.
Consequently, yes, much smaller doses of human antibody are needed to provide effective therapeutic concentrations that last for several weeks. So these advantages, particularly the significantly lower risk of potentially severe hypersensitivity reactions and the substantially prolonged duration of effect, strongly point to the desirability of using human antibodies for passive protection whenever possible.
It's a clear illustration of how biological compatibility translates directly into better patient safety and efficacy.
Absolutely. If we connect this to the bigger picture, the evolution of these products from raw, unpurified animal sera, which were fraught with risks like serum sickness,
Which sounds awful.
to the highly purified, often human-derived immunoglobulins we have today, reflects a profound and continuous advancement in patient safety and efficacy over the last century or more. It's a journey from crude, potentially highly reactive treatments to sophisticated, highly targeted interventions that are remarkably safer and more effective.
It's a powerful testament to centuries of scientific progress in refining these life-saving tools, constantly striving for better compatibility and fewer side effects.
Absolutely. It really highlights the power of biochemistry and immunology working together.
Moving on to our next big theme. Section 2. Vaccines in Action, Public Health Impact and Current Challenges. And our source makes an incredibly powerful statement right off the bat here.
I think I know the one.
It says the development and availability of effective vaccines is a major success story in the battle against infectious diseases, and their impact on public health is rivaled only by the availability of clean drinking water.
It's a truly bold claim, isn't it?
It is. Rivaled only by clean water. That's huge.
It is, and it's absolutely deserved when you think about it. Think about why these two interventions are considered so foundational, so transformative for human society. Clean drinking water.
Stops cholera, typhoid, dysentery. All those waterborne killers.
Exactly. It prevents the massive transmission of waterborne diseases, fundamentally altering survival rates, especially for infants and children, and allowing cities to grow without becoming death traps. Similarly, vaccines prevent the person-to-person spread of highly communicable diseases like measles, polio, diphtheria, smallpox.
Diseases that used to wipe out huge portions of the population.
Absolutely. So both interventions don't just treat sickness, they fundamentally change the landscape of human existence. They allow for dense population, enable urbanization, industrialization, massive population growth, and dramatically longer lifespans that were simply unimaginable before these interventions became widespread.
So they really built the foundations of modern public health and society.
You could strongly argue that, yes, historically, scourges like smallpox, which, let's remember, has been globally eradicated entirely due to vaccination.
A monumental achievement.
Truly monumental. Or polio, which is now on the very cusp of eradication thanks to decades of relentless global vaccination efforts. These diseases once caused widespread death, lifelong disability, paralysis, blindness, and pervasive societal fear. Their near elimination is a direct result of successful, widespread vaccination programs. It's prevention on a massive societal scale.
It's a powerful success story. But as our source highlights, this incredible triumph isn't without its contemporary challenges. We're unfortunately seeing a resurgence of some preventable diseases.
Yes, and measles is a stark, very concerning example.
Why measles specifically?
Measles is incredibly contagious, one of the most contagious viruses known, and it requires very high population immunity, around 95% vaccination coverage to prevent outbreaks. This makes it a very sensitive indicator when vaccination rates start to slip.
Like a canary in the coal mine for herd immunity.
That's a perfect analogy. Our source notes that through the first 5 months of 2019, there were more cases of measles reported in the United States than in any year since 2000.
2000 being the year it was declared eradicated from the U.S.
Exactly. So, going backwards, this alarming reemergence is primarily linked to clusters of infection within undervaccinated populations, often facilitated by international travel to or from countries where measles is still endemic, meaning it circulates regularly.
And the data connects this to vaccination status.
The data is very clear, according to the source. The vast majority of reported cases occurred in patients who were not vaccinated against measles.
And measles isn't a benign childhood illness, is it? Sometimes people talk about it almost nostalgically, like, oh, everyone got measles. But it carries significant dangers.
Far from benign. It's a serious and potentially deadly disease. The source reminds us it causes death in 1 to 2 of every 1,000 patients who contract it, even in developed countries with good medical care.
1 or 2 in 1,000. That's not trivial if millions get infected.
Not at all. And globally, despite widespread vaccination efforts, the WHO estimates that over 100,000 people, mostly young children, continue to die annually from this highly communicable disease. It's not just a rash and a fever, it's a severe illness with potentially serious
That's
complications.
such a...
Pneumonia is a common one, also severe diarrhea leading to dehydration, ear infections that can cause hearing loss, and encephalitis, swelling of the brain, which can lead to permanent brain damage or death.
And there's a delayed complication, too.
Yes, a rare but devastating one called subacute sclerosing panencephalitis, or SSPE. This is a fatal neurological disease caused by persistent measles virus infection in the brain, which can appear years, even decades, after the initial measles infection.
That's terrifying. So the mechanics of how these outbreaks occur, it comes down to herd immunity again.
It absolutely does. When vaccination rates drop below that critical threshold, around 95% for measles, the protective effect of herd immunity or community immunity diminishes significantly.
Could you just quickly recap herd immunity?
Sure. It's when a sufficient portion of a population is immune to a disease, either through vaccination or prior infection, making it difficult for that infectious disease to spread from person to person. This provides indirect protection even for those individuals who can't be vaccinated.
Like very young infants or people with severely compromised immune systems.
Exactly. They rely on the immunity of the herd around them. When pockets of undervaccinated individuals exist, perhaps due to vaccine refusal or lack of access, the disease can easily gain a foothold again if introduced, often via travel, and then spread rapidly within that susceptible group, potentially spilling over into the wider community.
And the source mentions tools used to combat this, specifically referencing the anti-vaccination movement. It talks about patient education and, in some cases, mandatory vaccination legislation.
Yes, it presents these neutrally as strategies that public health bodies and policymakers employ to address declining vaccination rates and the resulting disease outbreaks.
So patient education to address misinformation and concerns.
Right, trying to build trust and provide accurate information about vaccine safety and efficacy. And mandatory vaccination legislation, often for school entry, as a policy tool to ensure high enough coverage levels to maintain herd immunity and protect the entire community.
This really brings up that profoundly important and often debated societal question, doesn't it?
It does. How do we, as a collective, balance individual autonomy and personal choice with the collective good of public health, especially when dealing with highly communicable diseases that can seriously impact not just the unvaccinated individual, but the entire community, particularly the most vulnerable members?
It's a complex tension.
It is. Our source highlights the real world, often stark, public health consequences of undervaccination through the example of measles reemergence. The tools mentioned, education and legislation, are presented as public health responses to this challenge, aimed at maintaining the high levels of population immunity necessary to prevent epidemics and protect everyone. It's a complex societal debate with significant ethical dimensions, but from a purely public health perspective, the ultimate goal is always to safeguard the health of the entire population.
That sets a clear context for the societal stakes involved. So let's transition now to Section 3, navigating the immunization landscape. Because it's not just about getting one shot. It's about following a carefully designed schedule, often a lifelong journey of protection.
Yes, it's a very deliberate process. Our source references the recommended routine childhood immunization schedule in Table A2, along with general adult recommendations. And the philosophy behind these schedules is incredibly sophisticated.
It's not just random timing.
Not at all. It's carefully considered by scientific and public health bodies like the CDC's Advisory Committee on Immunization Practices, ACIP, in the U.S., and similar bodies globally. For children, it's a phased approach.
Phased how?
It's strategically timed to protect infants and young children precisely when their immune systems are developing and, crucially, when they are most vulnerable to specific, potentially severe diseases. For instance, the hepatitis B vaccine series starts right at birth.
Okay.
Then multiple doses of common childhood vaccines like DTaP, that's for diphtheria, tetanus, and a cellular pertussis, whooping cough, IPV for polio, Heb for Haemophilus influenza type B meningitis, PCV for pneumococcal disease, and RV for rotavirus gastroenteritis, are typically given in the first 6 months, often at 2, 4, and 6 months.
Busy first year?
Very busy. Then crucial first-year vaccinations like MMR for measles, mumps, and rubella and varicella for chickenpox typically occur around 12-15 months, often after maternal antibodies have waned.
And it continues into adolescence.
Yes, boosters are important. Tdap, which boosts tetanus, diphtheria, and pertussis protection, HPV for human papillomavirus, and MCV for meningococcal disease, are typically recommended around 11-12 years. These ensure sustained protection as immunity from earlier doses might start to decrease over time.
It's quite an intricate, meticulously planned roadmap. And it's clear that some vaccines require multiple doses, not just one and done. What's the science behind needing boosters?
That's a critical point for building robust, long-lasting immunity. For example, the source notes hepatitis B vaccine usually requires 3 doses for full protection in infants, and rotavirus vaccine requires 2 or 3 doses depending on the specific brand used.
Why multiple doses?
These multiple doses, often called a primary series followed by boosters, are essential for several reasons. First, they strengthen the initial immune response to generate higher antibody levels. Second, they broaden the range of immune cells that recognize the pathogen, making the response more resilient. And third, and perhaps most importantly, they establish a strong, long-lasting immune memory.
So the immune system needs reminding sometimes.
You can think of it that way. It needs repeated exposure to an antigen sometimes to fully learn and refine its response, ensuring durable protection that lasts for years, maybe even decades. Our source also highlights some important scientific details within these schedules, like mentioning that some vaccines, such as Hibib, meningococcal conjugate, and pneumococcal conjugate vaccines, are conjugated to protein.
Conjugated to protein, that sounds quite technical. What does that actually mean for a child's developing immune system, and why is it such a key scientific advancement?
That's a great question, and it's a brilliant piece of immunological engineering, really. Many dangerous bacteria, like Haemophilus influenza type B or Streptococcus pneumonia, have an outer coat, a capsule, made of polysaccharides, long chains of sugar molecules.
Okay.
The problem is, these polysaccharide antigens are often poorly immunogenic in young children, especially under 2 years old. Their developing immune systems find it hard to see these sugars and mount a strong T-cell dependent memory-generating response.
So the standard approach doesn't work well for those bacteria in kids?
Not optimally, no. So when we say conjugated to protein, we mean that these bacterial polysaccharides are chemically linked, or conjugated, to a carrier protein, often a harmless protein like tetanus toxoid or diphtheria toxoid variant.
Like adding a handle to something slippery?
Or like adding a prominent, brightly colored flag to a stealthy enemy. The carrier protein acts as that flag. It's easily recognized by the T helper cells in the immune system. When B cells recognize the polysaccharide, they also process the attached protein flag and present it to these T helper cells.
And the T cells help?
Yes. The T helper cells then provide powerful signals back to the B cells, driving a much stronger, more robust antibody response to the polysaccharide, and crucially, generating long-lasting immune memory. It essentially converts a weak T-independent response into a strong T-dependent one.
That's clever. It allows infants to fight off bacteria they otherwise couldn't handle well.
Precisely. It allows infants and young children to mount an effective immune response against pathogens like Hib and pneumococcus, which used to cause devastating meningitis, pneumonia, and sepsis in that age group before conjugate vaccines were developed. It was a revolutionary advance in vaccinology.
And the source mentions other nuances too.
Yes, things like the route of administration. The rotavirus vaccine, for instance, is given as drops in the mouth orally.
Why orally?
Because rotavirus infects the gut, so delivering the vaccine orally helps stimulate strong mucosal immunity right there in the intestinal lining where protection is needed most. It mimics the natural route of infection.
Makes sense.
And it also mentions the intradermal option for the influenza vaccine for adults. This involves a much shallower injection into the skin layer, the dermis, often using a special microneedle device.
And the benefit of that?
The skin is rich in immune cells, so potentially a smaller dose of vaccine antigen delivered intradermally can elicit a comparable immune response to a larger dose given intramuscularly. These are specific innovations driven by the need for more effective, more convenient, or perhaps dose-sparing delivery methods.
So what does this all mean for you, the learner, taking this deep dive? It really hammers home that staying protected isn't a one-and-done deal, is it?
Not at all.
It's a dynamic, carefully orchestrated schedule, meticulously tailored to age, based on when you're most vulnerable, reflecting evolving risks, and leveraging the sophisticated nuances of the human immune system and vaccine technology. Yeah, it truly is a lifelong commitment to comprehensive protection.
Absolutely. And that need for adaptability extends far beyond routine childhood and adult schedules, especially when we consider global travel.
Right. Our next point. Immunization for global citizens. travel, and beyond. If you're crossing borders, especially internationally, you have additional responsibilities and specific requirements.
Indeed. Our source is very explicit about this. Every traveler must fulfill the immunization requirements of the health authorities of the countries they plan to visit. These aren't just suggestions, they can be legal requirements for entry.
So you need to check beforehand.
Absolutely. It points to critical resources like the CDC's Health Information for International Travel, often called the Yellow Book, the CDC website itself, specifically www.nc.cdc.gov travel, and specialized publications like the Medical Letter on Drugs and Therapeutics as essential guides.
For travelers and their doctors.
Yes, both. These resources provide up-to-date information on required vaccines, like yellow fever for certain parts of Africa and South America, and recommended vaccines based on destination, activities, and length of stay, things like typhoid, hepatitis A, Japanese encephalitis, etc.
And you need proof.
Often, yes. Immunizations received specifically for travel should be recorded on the International Certificate of Vaccination or Prophylaxis, ICVP, often called the Yellow Card, which serves as your official global health passport for certain required vaccinations.
So the practicality of travel immunization is really twofold.
Exactly. First, it prevents the spread of diseases across borders. It protects global public health from imported pathogens. You don't want to bring yellow fever back home or take measles to a remote island. Second, and very importantly, it critically protects the individual traveler from endemic diseases they might encounter in different regions, diseases their domestic immune system might never have seen and has no defense against.
And the source makes a particularly striking note about smallpox.
Yes, it's a point worth repeating because it speaks volumes about global public health success. It explicitly states that smallpox vaccination is no longer recommended or required for travel in any country.
Because it's gone.
Because it's eradicated, wiped off the face of the earth in the wild thanks to a massive, coordinated global vaccination effort led by the WHO. It's a monumental achievement, a direct testament to the power of vaccines and international cooperation, eliminating a disease that once plagued humanity for centuries, killing hundreds of millions.
That truly highlights how global travel makes understanding and adhering to vaccine requirements not just a personal health choice, but really a collective global public health responsibility.
Absolutely. You're not just protecting yourself, you're actively participating in preventing the reintroduction and spread of diseases into new populations and safeguarding global health security for everyone. It underscores the profound interconnectedness of global health in our modern world, where a disease outbreak anywhere can potentially be a threat everywhere relatively quickly.
Finally, let's explore Section 4, the unseen hurdles, legal and production complexities. This is where we get into some of the broader, less talked about, but equally critical issues surrounding the availability and development of vaccines and these other biologic products.
Right, the behind-the-scenes challenges.
It begins with the fundamental physician's role and patient responsibility.
Our source is quite unequivocal on this point. It is the physician's profound responsibility to inform the patient adequately about the risks associated with immunization, alongside the benefits, of course.
Informed consent.
Exactly. And also to use vaccines and anti-sera appropriately and ethically, following established guidelines. This includes, when necessary, performing skin testing to assess the risk of an untoward reaction, particularly, as we discussed, with animal-derived products like anti-venoms, to proactively identify potential hypersensitivity.
So it's about communication and careful practice.
Yes. This requirement highlights the deep ethical and practical implications of informed consent in the context of immunization, ensuring patients truly understand both the immense benefits and the rare potential risks, however small, empowering them to make informed decisions about their health in partnership with their doctor.
And the source adds a pragmatic point that some risks are currently unavoidable. No medical intervention is entirely risk-free.
That's a reality of medicine.
However, it states that, on balance, the patient and society are clearly better off accepting these rare risks for routinely administered immunogens, like the annual influenza vaccine or routine tetanus boosters, given their overwhelming benefits in preventing widespread illness, complications, and death.
This raises an absolutely vital and complex question, doesn't it? It's really at the heart of public health ethics and population-level medicine.
Which is?
How do we ethically and practically weigh the rare, often statistically inevitable individual risk against the immense collective benefit when it comes to widespread public health interventions like vaccination programs?
That's a tough balance.
It is. It highlights the fundamental challenge of population-level medicine, where decisions are made not just for one person sitting in front of you, but for the health of millions. While no medical intervention is entirely risk-free, the overwhelming scientific and historical evidence for the safety and efficacy of routine vaccinations clearly demonstrates that the societal benefits preventing epidemics, reducing severe illness and death, protecting the vulnerable, maintaining community health and economic productivity far outweigh the incredibly rare individual risks. It's a risk-benefit calculation that society, through its public health institutions and regulatory bodies, has broadly determined to be strongly in the collective best interest.
This leads us directly to another highly complex and, frankly, often contentious issue: manufacturer liability and the public good.
Ah, yes, the economics and law intersect here.
This is where the legal and economic realities behind vaccine development get really interesting and reveal a profound societal paradox, it seems. Our source states that manufacturers should, quite rightly, be held legally accountable for failing to adhere to existing standards for the production of biologicals.
Of course. Quality control, good manufacturing practices, absolutely essential. If they mess up, they should be liable.
That makes perfect sense for ensuring quality and safety. But then it adds a powerful and sobering observation. It says, quote, "In the present litigious atmosphere of the USA, the filing of large liability claims by the statistically inevitable victims of good public health practice has caused many manufacturers to abandon efforts to develop and produce low-profit but medically valuable therapeutic agents such as vaccines."
That's a truly stark claim and a well-recognized issue in the field.
Let's unpack statistically inevitable victims, because that phrase really jumps out. What does that mean in this context?
It refers to the cold, hard statistical reality we just touched upon. Even with a vaccine or biologic that is designed, manufactured, tested, and administered with the utmost safety and quality control, meeting all regulatory standards, and is overwhelmingly safe for the vast majority of people.
Yes.
If that product is administered to millions or hundreds of millions of people, as routine vaccines are, a tiny, tiny fraction of a percentage will, simply by chance and individual biological variation that we often don't understand, experience a serious adverse reaction.
Even if the vaccine itself isn't faulty.
Correct. These reactions are not necessarily due to manufacturing defects, negligence, or a poorly designed product. They can be rare, unpredictable biological responses in certain susceptible individuals that can occur even in a perfectly implemented beneficial public health program. In a highly litigious environment, however, these rare adverse events, however tragic for the individual, can lead to massive liability claims and protracted, expensive legal battles against the manufacturer, regardless of whether there was any actual fault or negligence on the manufacturer's part.
And the economic consequences of that are profound, aren't they? Why would manufacturers abandon low-profit but medically valuable agents, especially given their critical importance to public health? That seems counterintuitive.
From a purely business and economic perspective, it unfortunately makes a certain kind of cold logic. If the potential financial liability from lawsuits stemming from these statistically inevitable adverse reactions is perceived to be so astronomically high, potentially running into millions or billions of dollars over time, that it outweighs the relatively modest profit expected from producing essential but often low-margin vaccines.
Then the risk isn't worth the reward, financially speaking.
Exactly. Manufacturers, especially smaller ones, or those considering entering the market, might quite logically choose to stop producing certain existing vaccines, or perhaps more critically, decide not to invest the huge sums required for the research and development of new, needed vaccines. Vaccines, while indispensable public health tools, are not typically blockbuster drugs generating massive profits. They're often purchased by governments or large programs at relatively low prices per dose.
So this creates a significant disincentive.
A huge disincentive for vital public health innovation. It can potentially leave society without critical tools to combat existing and emerging infectious diseases. It's a classic example of where the tort liability system, designed to compensate injured individuals, can inadvertently create a barrier to achieving collective health goals, particularly for products like vaccines that have broad societal benefits but also carry rare inherent risks.
And the source goes further, arguing specifically against applying strict product liability in this context. What exactly is strict product liability, and why might the source suggest it's inappropriate here given the unique nature of vaccines and biologics?
Okay, so strict product liability is a legal doctrine that holds a manufacturer liable for harm caused by their product without the need for the injured party to prove negligence or fault. Basically, if the product caused harm during normal use, the manufacturer is liable, period, even if they followed all safety protocols, adhered to all government guidelines, and didn't act negligently in any way.
Liability without fault.
Correct. The argument presented in the source, which reflects a long-standing debate, is that since the use and sale of these biological products are subject to incredibly careful, rigorous review and approval by highly authoritative government bodies, the source mentions the Surgeon General's Advisory Committee on Immunization Practices, ACIP, and the U.S. Food and Drug Administration, FDA.
Right, they undergo intense scrutiny.
Exactly. Because of this intense government oversight and approval process, applying strict product liability may be an inappropriate legal standard. The reasoning is, if a vaccine is made perfectly, meeting or exceeding all stringent government standards for safety and efficacy, and is administered according to government guidelines, and yet a rare, unpredictable adverse event still occurs due to individual biological factors,
Then holding the manufacturer liable without any fault on their part seems unfair.
that's the crux of their argument. It could be seen as unfairly punishing the manufacturer for doing everything right according to the rules set by society's own regulatory bodies. And, more importantly, as we discussed, this perceived unfairness and the sheer financial risk can deter companies from engaging in the difficult, costly, and often low-profit but societally crucial work of developing and producing essential public health tools like vaccines. It's a complex legal and ethical dilemma that society, particularly in the U.S., has grappled with for decades, leading to things like the National Vaccine Injury Compensation Program.
Trying to balance individual compensation with ensuring vaccine supply.
Precisely. If we connect this to the bigger picture, the legal and economic framework surrounding biologicals directly impacts their availability, their safety oversight, and crucially, their future development pipeline. It's a delicate and critically important balance that must be struck.
A balance between
Protecting the public from harm and compensating those rarely injured on one hand, and fostering the innovation and ensuring the reliable manufacturing supply necessary to create and distribute life-saving medicines like vaccines and immune globulins on the other. It's a tension that plays out constantly in the real world, impacting public health preparedness and response, and our source brings this complex interplay into sharp, expert-level focus.
So what does this all mean for you, having taken this truly deep dive with us? We've explored the intricate dance between active and passive immunity, haven't we?
We certainly have, from your body building its own robust long-term defenses.
You borrowing powerful pre-innate antibodies for immediate short-term protection when needed. We've journeyed through the incredible triumphs of vaccines and eradicating or controlling diseases that once plagued humanity.
Think smallpox, polio.
And face the stark realities of contemporary challenges, like the measles resurgence, that remind us just how vital these public health interventions are, and maybe how fragile their success can be without ongoing collective action and trust.
Yeah, that point about community immunity is so critical.
And we've even pulled back the curtain on the complex legal and economic landscape that shapes the very availability of these vital tools, understanding the profound nuances behind every vaccine and immune globulin that reaches a patient.
We've truly peeled back the layers on a field that is constantly evolving, driven by relentless scientific discovery, meticulous research, and ever-present societal needs. The sheer depth of detail in our source material.
It's impressive.
It really is. From the specific components of a DTaP vaccine and the precise timing of its doses based on developmental immunology, to the nuances of manufacturing and administering immune globulins for rare but life-threatening conditions like a scorpion sting or botulism. It just underscores the incredible complexity, precision, and dedication involved in protecting human health on a global scale.
It's a testament to the meticulous work of countless scientists, researchers, public health professionals, manufacturers, all working tirelessly behind the scenes.
Absolutely.
Indeed, it's clearly more than just a shot in the arm. It's a symphony of cutting-edge science, informed public policy, complex economics, legal frameworks, and ultimately individual and collective choices, all of which have to come together to contribute to the health and well-being of our entire society, shaping how we live, how we travel, and how we interact safely with the world around us.
Well said.
So, as you reflect on this deep dive, consider how your understanding of immunity and public health now shapes your perspective on global health challenges and the ongoing critical role of scientific innovation in protecting us all. And maybe think about this. What other areas of public health, perhaps less discussed, do you think are similarly complex, constantly balancing that delicate line between individual choice and autonomy and the overarching collective well-being of the community?